Hi, everyone. We're going to wait just a minute to allow folks to join this session. While we wait, feel free to use the chat to say hello to your fellow attendees and let us know where you're from. Love seeing those check-ins. Okay, let's get started. Hello, everyone, and welcome. Thank you for joining the Marfan Foundation and its divisions for our 2026 Global Virtual Conference session titled Eye Issues and Key Management Considerations in Connective Tissue Conditions. I'm Lauren May, Senior VP of Research. My colleague, Olivia Abel, is the Marfan Foundation's Director of Integrated Marketing Communications, and she's behind the scenes helping to keep everything on track today. This session is being recorded. Before we begin, please use Zoom's Q&A feature to submit questions throughout the presentation. We'll answer as many as possible during the Q&A session at the end. The chat is available for attendee discussion and comments. We love those, but questions posted there may be missed, so please use the Q&A tab. I am honored to introduce our speaker today. Dr. Jefferson Doyle is Assistant Professor of Ophthalmology and Genetic Medicine and co-director of the Genetic Eye Disease Center at Wilmer Eye Institute at Johns Hopkins. He runs a dedicated genetic eye clinic where he sees many patients with connective tissue conditions, including Marfan, LDS, Stickler, and Ehlers-Danlos syndrome. Dr. Doyle, thank you for joining us. We're delighted to have you here. Please begin whenever you're ready.
Sounds wonderful. Thank you, Lauren. Thank you so much. And hopefully people can see my slides now.
They're perfect.
Okay, wonderful. Well, it's a pleasure to be here. Thank you to the foundation for the opportunity to come and speak. I thought I would share, some of our experiences related to the eye issues and management considerations in connective tissue conditions. This is really based on our experience of many of the patients that we see in clinic every week. My background is I'm a pediatric ophthalmologist with a background in genetic medicine, and I run a translational research laboratory that studies ocular issues in connective tissue disorders. I have a couple of disclosures that are not relevant here. And so I'm going to break it up by disorder and talk a little bit about each of the main things. So, for example, we'll start with Marfan syndrome. This is a picture of an eye here, and just to orientate everybody. So this is the front of the eye, which we call the cornea. This is where light rays come into the eye. It passes through the anterior chamber, which contains a clear fluid. And then you have the iris, the colored part of the eye that you see here. The center of the iris, which we call the pupil, is the opening, and then light rays pass through the lens that helps focus the light rays inside the eye. These pass through, I'm going to use a pointer to see if this is easier. Light rays pass through the vitreous chamber, a jelly-like substance, to the back of the eye, where they come into focus the center of the retina at the back. This is the light-sensing tissue in the eye that transmits this information along the optic nerve to the brain. And so I'm going to talk through each of these structures. So we see corneal changes in Marfan syndrome. We see differences in the iris to the general population. Patients with Marfan are at increased risk of glaucoma. So we'll talk a little bit about fluid draining out of the eye and the effects that it can have on the nerve. Strabismus, or misalignment of the eyes, is where there is involvement of the eye muscles, so we'll talk a little bit about that. Amblyopia, which is where the brain does not see as well as it should do. It cannot use the eye as well as it should do. This can be for a couple of different reasons that we'll touch upon, and its management. And then some of the prominent features we think about in Marfan syndrome are the lens itself. We'll talk about changes in this, the retinal complications that can occur, as well as the nearsightedness that develops. So we'll go through each of these main points and break them down individually. So we'll start with talking about ectopia lentis, or EL, as we sometimes call it in Marfan syndrome. And this is talking about the lens just here, where you can have dislocation of the lens. And it occurs in the majority of patients. And it can occur in any direction. So when it does dislocate, and I'm looking in at your eye at the slit lamp, this is what I'll often see. So the pupil here is dilated to make it easier to see inside the eye. And normally the edge of the lens that we see here, we should never see. If the lens is nicely centered, all we do is look through the clear lens. Instead, you can see here that the lens is displaced upwards and that there's these tiny little fibers, which we call zonules, that are designed to hold the lens in place centrally inside the eye. And if the lens displaces, we can sometimes see these zonules, or occasionally they'll be missing as well. So there's different features associated with that. A lot of the time, this can present with nearsightedness, or myopia, as we call it. I'll talk a little bit more about this in due course, but this is where light rays coming into the eye come into focus in front of the retina. The more round the lens is because of any displacement, this leads it to focus light rays more strongly. It can create astigmatism. So when a lens displaces, the lens is displaced upwards here, the lens actually becomes slightly more round in the direction of displacement, and that creates astigmatism, whereby the strength of the prescription differs depending on the angle that you're looking at. And then something else that can happen is as the lens becomes more round because the zonules are weaker, and so there's less tension on those zonules, there's reduced ability for the eye to focus up close and see it near, something we call accommodation. So these can be all of the features that first present. Things we worry about. So in children who are young, visual development occurs for about the first 7 years of life. When a child is first born, they generally see about 2200, which is pretty close to legal blindness. It's only really by the age of about 7 that kids tend to see 20/20. And over those intervening 7 years, if you have anything that impairs the brain's ability to use the eyes to see well, kids can develop something called amblyopia. So we worry that they present and their vision is not as good as it should be for their age. Occasionally, you can also get blurred vision or even double vision if the lens displaces either totally outside the visual axis, or if it, as in here, the lens edge comes very close to the center. If half the eye is looking around the lens and half through it, you can end up with a double vision that develops from one eye. So general treatment, my general approach to connective tissue disorders is do the least invasive thing possible to get the solution that you need. They're such delicate eyes. So I generally aim for glasses correction for as long as possible. Occasionally, if someone can't see up close, we will add a bifocal component, even if they're a kid, to help them see better at near if they can't fully accommodate, or contact lenses as well, if that's a better alternative, if kids or adults can tolerate it. Occasionally we'll consider surgery for the lens if it's impairing vision. And the options are we can take a lens out and leave the eye without a lens. That's generally my personal preference. If an eye is still growing, it's very hard to know exactly what new lens to put in. So I'll take a lens out. I'll use either glasses or contact lenses to get the eye in focus, let the eye finish growing, and then consider whether we put a new artificial lens into the eye later. I do know that some centers try to centrate the lens that is already there. So with extracapsular support mechanisms or suturing it to the eye wall, that's generally not my preference. And then for later on, if we want to suture a new lens into the eye, we can discuss that if people have questions about it. There's a number of different things to consider. I've got some lines in red here. I wasn't sure if it was only patients who are attending or if it was also physicians interested in connective tissue disorders. So I've got some lines in red in some of my slides that's perhaps slightly higher level discussion points, either for physicians or parents who are very experienced in discussing this. What I will generally say, some of my comments from seeing many, many kids with Marfan syndrome over the years, is that amblyopia generally is actually less than a lot of my pediatric ophthalmology colleagues worry about. So I tend to be a little more conservative and leave the lenses in place longer than most. Other things from experience of seeing a lot of patients, for a lens that's been in there for many, many years, sometimes it can actually, as it becomes very dense, you can get little lens fibers that leak out and cause inflammation or glaucoma. And so I will always follow patients who have retained lenses annually to make sure that this is not something that's developing down the line. And in terms of actually suturing new artificial lenses into the eyes, there's a number of nuances that I always discuss with patients that we can cover if anyone has any interest at the end. So another feature in Marfan syndrome is the nearsightedness, or often the very severe nearsightedness, so high myopia, as we call it. And essentially, what happens is compared to a normal eye, where light rays come into focus at the back of the eye, exactly on the retina, as I mentioned before, because either the eye grows too long, or because of the shape of the lens or sort of shape in the cornea, then actually the light rays come into focus in front of the retina. That's really the definition of nearsightedness or myopia. And the further in front they come into focus, the higher the prescription. And so it can really be a combination, as I say, of either the eye growing too much, the lens, or a combination of two. In terms of symptoms, patients will often see better at near than they can in the distance. That's really one of the key features of nearsightedness. And again, when we think about treatment, my goal is minimum possible. Glasses or contact lenses, if they suffice, then great. Occasionally considering that bifocal, as we said, and again, removing the lens occasionally only if we have to, if it becomes so severe that we can't get glasses that work or contact lenses are intolerant or for some other reason. I will just mention that we have ongoing research in our lab. One of the features about eye growth occurring too much in Marfan syndrome, it can be very severe and lead to a number of complications. And sort of analogous to all the work that is done with aortic aneurysm in Marfan syndrome and other connective tissue disorders, there are really no proven ways to slow eye growth in Marfan syndrome if you identify it. So that's actually an area of research in our lab. We've been studying using Marfan mouse models to try and identify new therapies. And it seems as though there may be a couple that appear effective in mice that we will hopefully be sharing soon. In terms of the retina and Marfan syndrome, this is one of the major causes of vision loss and irreversible vision loss. So some of the most common features we see is retinal detachment. So this is where that fine layer of tissue at the back of the eye, the retina, if you get a hole or a tear, it can start to peel off almost like a suction cup coming off the back of the eye. So this is an example of a retinal detachment here. If it's only in the periphery, if you can actually have surgery to reattach it before it involves the center of the vision, then the outcomes in terms of your long-term vision are significantly better. And therefore, that's why we class it as an emergency to get it seen as soon as possible to try and preserve that central vision if at all possible. There are other changes as well that occur when the eye grows very large. So there can be degenerative changes in the center of the retina that actually we don't really know how to reverse well yet, but that can cause bleeding and vision loss in the center of the eye. And there can be other features as well, where the eye wall, the white of the eye, the sclera can become very, very thin, and you get outpouching of the tissues inside the eye coming out through the sclera. Typically, this occurs at the back of the eye, so it can't be seen, but I certainly do have examples of severe cases where it occurs much more anteriorly like this, and the eye wall can get incredibly thin and problems that come with that. That's something called a staphyloma. So in terms of symptoms, retinal detachment symptoms, I'll always discuss with patients, usually at every visit, just to reiterate. So if you have any new or persistent flashes of light, like a firework display going off inside the eye, any new or worsening floaters, so black dots or lines in the vision that move around, or any curtain coming down over the vision, then they're all reasons to see someone straight away. I really say same day for that. Sometimes in patients who have migraines or low blood pressure, then we talk about distinguishing the symptoms. If the flashes of light, are they different in any way from your typical migraine features? Or in the postural hypotension, where you stand up, you get a bit dizzy, both vision can come down to a tunnel vision, are usually a little distinct to the retinal detachment symptoms that we see. In terms of treatment, so urgent evaluation, same day certainly. And I usually say to patients, as soon as you detect something, stop eating or drinking. So if you go and get evaluated and they want to do any surgery, they can go ahead and do that as soon as possible to avoid the delay. There's different types of surgery. So a scleral buckle, putting a silicone ring around the outside of the eye, going into the eye to remove the vitreous jelly and reattaching the retina. And sometimes they tamponade that by helping flatten the retina against the eye wall with cryotherapy, gas, or oil, all depending on the particular situation they find at the time of surgery. We also, you can see cornea and iris changes in Marfan syndrome. So generally in Marfan patients, the cornea is thinner than usual and it's actually flatter than usual. So it's less round. And this can sometimes offset some of the nearsightedness that come from the eye growing too much or the lens displacing. Keratoconus is a disorder that's talked about. So this is where I've tried to show an illustration here. This is the normal curvature of the cornea, and where you get thinning of the mid-peripheral cornea. So you're effectively getting a flattening cone-like shape to the cornea. That's actually what this means. It means cornea cone, keratoconus. This is something that's reportedly increased in Marfan syndrome. I will also say the iris, the colored part of your eye, is often very flat and very velvety, almost looks a fine layer of velvet, because the underdevelopment of the dilator muscles of the iris inside the eye. In terms of symptoms, a lot of the time, these corneal and iris changes, there's usually none. Some patients will have been told that they have very small pupils or they dilate very poorly. And that's certainly something that occurs because the underdevelopment of those dilator muscles. If there's any features of keratoconus, then things would often do become more apparent as it becomes more advanced and it precipitates. Sometimes you can suddenly get reduced or double vision, or your prescription changes very rapidly and is very variable, or glare and halos if the keratoconus becomes more significant. Typically, I'll always do what we call a pentacam image. So this is almost what I say to patients, a heat map of the surface of the eye. And this helps tell us how thick the cornea is, the shape of it, and whether there's any early signs for keratoconus, because again, early identification and intervention is much easier than subsequent repair. In terms of treatment, most patients don't need anything done for the cornea or the iris, simply just manage depending on what we find. In reality, the keratoconus risk still seems to be pretty low in Marfan syndrome from my experience of really seeing very few patients over time. Historically, I will say that we usually have advised in the ophthalmology world against LASIK, so the laser shaving of the cornea to counteract myopia in Marfan syndrome, or something similar, which is called PRK. Actually, I will say that I have had a couple of patients who had these procedures done before they were diagnosed with Marfan syndrome as an adult, and they've overall done fairly well with it. But I think we're still cautious because of the very high myopia, the thin cornea to start, and we worry about the structural integrity of the cornea if somehow these could be compromised further by doing the laser. So I'm still not a huge fan of it, but I do have that discussion with patients if they have questions about it. For any physicians that are present, I will say with the poor dilation of the iris at the time of surgery, then one of the things I find very effective, because a small pupil when you're operating is very challenging. I don't like using hooks to stretch the iris, particularly in children where it causes inflammation. And so using a pledget with a Q-tip just tucked under the eyelid for 5 or 10 minutes before surgery, I find makes a huge difference to the amount of dilation that you can get. Another feature that we can see in Marfan syndrome is glaucoma. So this is where there is damage to the nerve at the back of the eye. So this is what a nerve typically looks like. So when we look inside the eye, this is what we see at the back of the eye with all the blood vessels coming out through it. And I usually describe the nerve appearance as a bit like a bagel. So there's an outer ring here, and then there's an inner ring here that is about 1/3 the size of the outer ring typically. So what we call about a 0.3 cut to disc. If there is progressive change in this ratio where the inside ring gets bigger and bigger still, this is an example of, some moderate glaucoma and severe glaucoma. If we see these changes, we worry that there's damage to the optic nerve. In many patients, this is associated with high pressure inside the eye. Some patients can actually get these changes even with relatively normal pressure. And in Marfan syndrome, there's many different ways that glaucoma can develop. In Marfan syndrome, there's a good 5 or 6 that can contribute. So you have to be aware of those and thinking about those as well. In terms of symptoms, one of the challenges with glaucoma is it can often be totally silent. The enlargement of the cup in there causes a loss of peripheral visual field. So you can have a very severe constriction of your visual field before you ever even realize there's a problem. In fact, it can almost be a tunnel vision before you do. So the key really is it being picked up and detected, which is another reason for a regular eye exam. So occasionally, it will be that patients will be found to have high eye pressure, incidentally, an eye exam, and or evidence of optic nerve damage. Occasionally, glaucoma can suddenly precipitate very fast. For example, if the lens dislocates and blocks the pupil, and then in that instance, patients will often get sudden onset severe pain, a pressure type feeling, blurring of vision, and then you really need to seek advice the same day if you can. Some of the testing that you will see done if you have glaucoma, and we will often do screening for this to make sure there's no signs of it. So this is an example of looking at the anatomy of the optic nerve. This is what we call an OCT RNFL. And you can see here a left eye and a right eye. And the left eye shows a relatively small cut to disc, and all the values here in green telling us that the nerve fibers inside that eye are pretty good. In contrast to this eye, where the cup to disc ratio is significantly bigger, and you can see here the values are in the red, we have concerns. So this is something we follow. Something else that's typically done for glaucoma, at least in patients who are old enough to do it, you can't get a reliable visual field in young children. But this is a visual field, so a clicking light test, if you've ever had it, where you have to look inside a machine and press a button when you think you see a light flash. And this again shows in the right eye here, there's a blind spot showing black is bad and white is good, just a tiny little change in this right eye here, but significant peripheral field constriction from glaucoma in this eye here. In terms of treatment, it really depends on the mechanism and severity. So sometimes it's eye pressure lowering eye drops. Sometimes there's a laser procedure that can be done. Sometimes it can be surgery. If it relates to the lens, sometimes the lens removal itself solves the problem. Other times you need to have different types of glaucoma surgery. I think one of the key things that we've found over time in Marfan as well is, are the nerve changes that you're seeing actually true or artifactual? So what we will say is in a number of patients, not all, if we screen for glaucomatous changes using an OCT RNFL, then patients will actually show with Marfan syndrome an artificially low RNFL that will get flagged up. I think it's something just to do with the structural thickness of the nerve fiber layer inside a Marfan eye. And so we always go on and check with visual fields to make sure, is there actually any real damage, or is this an artifact of a Marfan eye? And particularly in patients, I will say, with very high axial length, so those very severe nearsighted patients, that can also make the interpretation a little more nuanced. In terms of moving on to Stickler syndrome, so this, and I'm sorry, these are relatively brief coverage of each one because it's a lot of material to cover the different disorders today. But I'm happy to answer any questions on it. So Stickler syndrome, a classical feature is very early onset high myopia at the first diagnosis. So often kids can present with very high severe nearsightedness. So kids are usually farsighted. And the reason is their eyeball is too short. So as light rays come into focus inside the eye, they focus behind the retina. So as a child grows, their eye grows and they grow out of that farsightedness. So myopia in a child means that the eye has already grown too much. So that's a red flag to suspect that something may be going on. And so very high myopia at an early age, particularly as we follow them over time, if that myopia does not get more severe but stays relatively stable, or if there's a family history of that, I'm always very suspicious for Stickler syndrome. And the big thing we worry about in Stickler syndrome is retinal detachment. So that retina coming off the back of the eye, it's close to a 50% risk in each eye. And a particular feature in Stickler especially is what we call these giant retinal tears, where it's a detachment that starts very close to the leading edge of the retina, and you get a big tear through the retina, a giant retinal tear that can be very challenging to repair. I have seen patients as well present with, for example, congenital cataracts. So they present at birth with cataracts that develop, and it's only because we measured the length of the eye at the time of surgery that we realized that it was unusually long and perhaps something else was going on. Occasionally, patients can present with congenital glaucoma. So again, glaucoma, very high eye pressure in a very young child that appears to have stretched the eye when actually it was a case of Stickler syndrome. So again, easy to miss if you're not thinking about it. And I will say that many patients in the family can actually have a relatively normal prescription. So you can have a patient that gets flagged up for their very severe nearsightedness. They're diagnosed with Stickler. There can be other family members that have a relatively normal prescription and they still have it. So it's important that we screen for that. When we're thinking about workup for patients, so examination, there's different changes of the vitreous jelly inside the eye that I always look for at the slit lamp, or I use a portable version of the slit lamp if it's young children. So these vitreous differences. And then a particular feature I always look for as well, especially in adults, is what we call lattice degeneration. So pigmentary changes that actually tracks along the peripheral blood vessels. I will say I very rarely see this in young children, but it's something that accumulates over time with age and is certainly a feature I'll always look for in parents of kids who have it. And then really genetic testing is absolutely key for this to pick it up. So having a level of suspicion. We could have an entire discussion on prophylaxis, so preventing retinal detachment in Stickler syndrome. There's different approaches that have been tried. So a freezing therapy all the way around the outside of the eye to really sort of tack down the retina to try and prevent those giant tears from developing. Others use a laser procedure to almost spot weld the peripheral retina. And then occasionally a scleral buckle, that's a silicone band that goes around the outside of the eye to help support it. There's all been studies looking at those that I'm happy to discuss if patients wish. I'll touch upon Loeys-Dietz syndrome. So this again shows some overlapping features with Marfan, but also some important distinctive ones. So as with Marfan syndrome, the cornea can be a little bit thinner than usual. The myopia, the nearsightedness, it tends to be milder than in Marfan syndrome because it's really only due to increased length of the eye, not the additional lens features that Marfan patients get. The amblyopia, so the reduction in vision because the brain didn't learn to use the eye well enough, can occur. And then strabismus, so misalignment of the eyes, we'll talk a little bit more about in a minute. In terms of the retina, you can certainly have the holes and the tears that develop, as well as the retinal detachments. There are rare cases of other features that have been described in the retina and Loeys-Dietz syndrome, so arterial tortuosity, some non-perfusion, so the blood vessels in the peripheral retina don't perfuse the retina as well. Some little aneurysms that can develop in the retina are some other features. But again, most of the data really on eye features in Loeys-Dietz are relatively rare case reports. So I think the true prevalence and significance of these, I think, are not that well established yet. I will say there's a couple of features in Loeys-Dietz that are a little more prominent than Marfan. So certainly there can be the wide spacing of the eyes, some drooping of the eyelids, some prominent eyes, and some blue grain to the sclera. And then certainly there can be eye issues that develop after a dissection of an artery elsewhere, listed here. So Horner syndrome is something that may have been described to some patients. Misalignment of the eyes because one of the nerves that controls the eye movements doesn't work. It got impacted by a dissection in the brain, as well as shaking of the eyes, nystagmus, and some visual field loss if the brain has been impacted. One thing I did want to talk about was strabismus, or in some parts of the world, it's called squint. So this certainly is relatively common in both Marfan syndrome and Loeys-Dietz syndrome. And this is really relates to a misalignment of the eyes. So normally when looking at someone, you see the eye straight ahead here. If an eye is turned in, it's called an esotropia. If the eye is turned out, it's called an exotropia. And if it goes up, a hyper, or down, a hypotropia. And these can be intermittent, where they just occur. A lot of the time, patients' eyes are not perfectly straight, but the brain wants to hold the eyes straight so it can see well out of each eye and use the eyes together. So sometimes it'll be intermittent. I saw several patients this morning with exactly this, where when their brain is fresh and they're alert, they can hold the eyes straight. As the brain gets tired later in the day, then they can tend to drift more. So symptoms, it may be that they don't feel anything other than people saying, oh, your eye's drifting up or your eye's drifting out. So in children, the thing we worry about again is if one of the eyes is going out a lot or up a lot, then the brain is not learning to use that eye as well as the other eye. So you can develop some amblyopia, as we call it, or the brain is not learning to use the eyes together so that a child doesn't develop adequate depth perception. So that's why we monitor for strabismus. And we also check to see if they do have some intermittent strabismus to make sure it's not having any impact on their visual development. In adults, in contrast, we will complain about it the moment it happens, that if an eye drifts off, we'll have to have some double vision. Sometimes we can pull that eye back together to make it single, and sometimes it reaches the point we can't. The treatment really depends on the type or severity of the strabismus. I usually start off with giving the optimum glasses to try and maximize how good each eye can see. The better the eyes can see, the easier it is for the brain to hold the eyes in good alignment. If that's not sufficient, so then sometimes if there's amblyopia developing in a child, we'll do patching of the good eye to force the brain to use the less good eye more, to try and strengthen the eye. And sometimes there'll be an eye drop called atropine that we use to blur the vision in the good eye to help use the less good eye. Occasionally, we'll need to proceed with surgery. So the idea really being to move the eye muscles, the positions, to physically bring the eye back into the best alignment possible. And I will say something I like to use is what we call adjustable sutures, where you actually put the muscles on a little slip knot when you align the eyes, so that if you wake the patient up after surgery, you can, if the eye is either too far in or too far out, you can tweak it further to get as good a result as possible, because a lot of the time connective tissue disorders don't follow the normative tables that most of us use for strabismus surgery. I will just mention, I put here a connective tissue specific. It may occur in other situations. I have never seen it anywhere other than a connective tissue disorder, where we go in and we look to do a surgery on the eye muscles, and we go to find a particular eye muscle and we just can't find it anywhere. What's interesting is if you go and look at the MRI imaging of a brain that's had it, you can see the muscles around the eye on the imaging, but sometimes surgically we get in there and we just can't find it. It's like it's not there. And so I've certainly seen a number of reports of this in Loeys-Dietz syndrome. I will say I've had a patient with Marfan syndrome where I had this as well. So I always tell patients ahead of time, look, we can go in and plan to do what we're going to plan to do. Occasionally we do have surprises like this in connective tissue conditions, and therefore just to be aware, we might have to change the plan at the time of surgery. I will briefly just finish by mentioning, so Ehlers-Danlos syndrome, there's many different EDS subtypes, as everyone here I'm sure knows, with varying ocular issues. One thing I'll mention, because I think it's less well documented in the literature, and it's something we see quite a lot of patients with hypermobile EDS who come and see us, and they will often have a constellation of really one or more of the same four sets of features. And classically, it's a double vision at near, where the eyes can't pull in well enough, so a convergence insufficiency, a blurring of vision at near because the eyes can't focus up close well enough, what we call an accommodative insufficiency, or AI now as appropriate. There can be eye pain or dryness and or reduced tear production, which is pretty common, as well as large pupils and light sensitivity. And a lot of the time, the patient's symptoms will be out of proportion to the signs that the eye doctor sees. I will say that a number of times I've had patients come in quite frustrated because they've been elsewhere and they've really been told, well, there's nothing wrong. You're just imagining it, when clearly they're in considerable distress from it. So what I tend to say in those instances is, I recommend minimizing some of the medications that they're using, because quite a number of medications have what we call anticholinergic, so anti-autonomic nervous system functions. And I do wonder if some of these can relate to that. So I often say, look, these particular medications, try and minimize the use, or if you need them, try and use the lowest dose possible. I will just mention for patients that have been told for convergence insufficiency, so they're pulling the eyes in to look up close, they've often been told to do training exercises to almost like strengthen the muscles that pull the eye in. I will say almost universally, I've never found that helpful in a connective tissue disorder. I don't think it's simply just the lack of muscle strength. I think there's more to the etiology than that. And for accommodative, reduced ability to focus up close, I will often try in a bifocal lens, as I mentioned before in Marfan syndrome. I will say that progressive lenses, a lot of adults prefer because they don't have the line across the vision that are bifocal, but almost universally, I tend to find my hypermobile EDS patients really don't like the distortion from progressive. So occasionally, if we do have to go ahead and do surgery, I will say that I often find patients have a greater degree of post-operative inflammation. So I often keep them on steroids, eye drops for longer. And I have had a few react to the dissolvable sutures we sometimes use. So those are features I'm always conscious of in the disorder. So a couple of general eye management guidelines to finish. So this is very broad, but I usually recommend an eye exam at the time of diagnosis. If it's in a child, preferably with a pediatric ophthalmologist, ideally with one with connective tissue experience. Generally an annual exam through the age of 7, where that's that visual developmental window, and more frequent if there's either impaired vision from lens issues, strabismus. Stickler syndrome needs to be more frequent as well, monitoring for retinal changes. For those that have been recommended ectopia lentis surgery, I will generally say a lot of the time, as I mentioned before, I tend to be more conservative than most just because I tend to find that patients actually still do pretty well in the long term. So I think meeting with someone with connective tissue experience, I think makes good sense. And if you do need the lens surgery, I think having someone who does it fairly regularly is certainly helpful. Stickler syndrome, I think certainly a discussion about retinal prophylaxis, thinking about that laser or freezing therapy, or occasionally a scleral buckle, I think is worth considering. And then once kids over the age of 7, then usually I tend to say an annual eye exam for updating glasses while kids are growing through teenage years until the eye is largely finished growing. And then a check retina more, an annual exam for all patients and more regularly than that for Stickler syndrome. And I always say any new symptoms, especially those retinal features, new onset flashes of light, worsening or new floaters or any curtain over the vision needs urgent evaluation. And for overall, there's relatively little data weighing one intervention over another in different connective tissue disorders. So I think that as a field is on us to try and improve in the coming years for you. Um, and I will just finish by saying thank you very much. This is the wonderful group of people I get to work with. And so, are both on the research side and the clinical side, this is the team that I rely on and greatly appreciate and value, who helps with a lot of the what I've talked about today. Thank you.
Dr. Doyle, thank you so much for your presentation. We've gotten several questions from attendees, and we'll go through those now if that works for you.
Of course.
Okay. The first question is from someone who has VEDS, and they have noticed over the years that their eyes are getting more and more red. Their veins are getting more thick and more red. And they've also noticed this in an older relative who also has VEDS. Is this a known issue with VEDS, and is there anything that this person can do to delay this effect?
Yeah, so it certainly has. Even in other connective tissue disorders, I've occasionally seen it as well. I think getting it evaluated to have a look just to make sure it's not a sign of anything else, I think is an important feature as well. So I think getting a full eye exam by someone who's experienced with seeing it is certainly helpful. Yeah, occasionally people who have quite prominent vessels will use essentially what are vasoconstricting eye drops. So you can get sort of anti-red eye drops from the pharmacy that essentially constrict blood vessels in the white of your eye to try and hide those vessels a bit. I'm not really a huge fan of those in general. I think generally your eye needs the blood supply that it has. So I generally don't recommend those. So again, I base that more on a case by case basis of what is the appearance of the vessels. Is it a sign of anything else? Have we done a full evaluation inside the eye to make sure there's nothing going on? And then a discussion really on sort of a case by case basis. But it certainly can occur, so it's not unique to.
Great, thank you. Is there any information that you can share about blue sclera that would be helpful for teens with Loeys, Dietz, and Marfan?
I don't know if the foundation themselves. I'm not sure if you have any handouts for that. If not, I'm happy to work with the foundation to come up with something if that would be helpful.
Yes.
Overall, the sclera, the white of the eye, is thinner in connective tissue disorders. It's really the gray or the blue is because you're seeing the tissue underneath, the choroidal tissue, the choroid. You're actually seeing it through the sclera. So the appearance, if it's a general mild appearance, that's not necessarily too worrying to me as the eye doctor. I understand as a patient it can be concerning or aesthetically sometimes. I think it's really where in patients where I see where there's a deeper areas of really severe thinning that I worry a lot more about risks of rupture, particularly in the setting of minor trauma. And so I do have a number of patients with areas where what we call scleromalacia, where there's incredible thinning and it looks as like there's just a couple of scleral fibers almost holding the eye together. Again, that's usually a discussion about, well, avoiding contact sports, protective eyewear, making sure that eye pressure is very well controlled because that in itself can help reduce that a little bit. So there are various nuances to it that sort of it depends. And I will say I see that in very young patients with Marfan syndrome that have severe forms sometimes. I've seen that in certain other types of like kyphoscoliotic EDS and others. So it certainly can occur in a number of disorders.
Okay, great, thank you. This person says that their 5-year-old daughter has Marfan syndrome, dislocated lenses, and is their process right now is that they're currently dilating her eyes to bypass the lenses, which has her seeing fairly well. Is this an approach that you would recommend, or would you move more in the lens removal direction at this point?
So, something I end up saying many times a day to patients is, the best intention doesn't always lead to the best outcome. And so my general rule is the least invasive thing possible in very delicate eyes is always my preference. So I think if creating some dilation is allowing her to see better, then I'm for the most part fine with that. If it avoids the need for surgery. As long as it's not compromising things in other ways, where causing too much light sensitivity by too much light getting into the eye and causing different problems. But for the most part, definitely it's my preference to leave the lenses in, if possible, for as long as possible. And sometimes eventually, if they displace out the way, then that's where if you can wait long enough for that to happen while still retaining good vision, then sometimes that almost solves the problem for you. It's effectively moving the lenses out of the way by nature rather than surgery. Although if you do have lenses that move out the way, I made mention of that, you still need the annual exam just to make sure that there's not any leakage of lens material that can cause other problems down the line.
Great. This is a question about Stickler. So, is there any data on epiretinal membranes in patients with Stickler syndrome after prophylactic 360-degree cryotherapy?
Gosh, you're racking my brains on so for the most part, the 360 cryotherapy, certainly the biggest study that was published a couple of years ago by someone, I was having lunch with about 3 days ago, Martin Sneed over in Cambridge in the UK, showed that for the most part, the cryotherapy had tend to do pretty well. I don't know, and really the risks of complications were really pretty impressively low. I don't recall the exact number of cases of ERM in that report. I'd have to go back and have a look. But I think the overall principle of it is that it seemed pretty well tolerated. and the dramatic reduction in detachment that came from that. Not only the reduction in the rate, but also the type of detachment, the fact that it really largely eliminated those really large, big, giant retinal tears that I talked about. I think that certainly, was an impressive study.
Great. And then just a follow up on that. What are the recommendations regarding monitoring intervals and timing of ERM surgery? And then if you're putting a cataract surgery into the mix, what do you recommend?
Well, yeah. So again, that's probably one of those questions that's a little more specific to the particular situation. So it's a little hard to give precise advice. But I think, the broad principles with ERM surgery is about, how bad is the ERM? How much does it appear to be impacting vision? What is the vision at the moment? And does it seem like that's more from the ERM or more from the cataract or a combination of two? And sometimes that can be hard to tease apart. So I think really that's probably something for one of our adult retina specialists where they can guide on that as to what the relative benefits and likelihood of benefit is. And without seeing it, it's a little hard to say. I'm
Sure.
sorry.
Understood. Understood. What is the percentage of reoccurrence of eye misalignment after bilateral exotropia strabismus surgery?
Yeah. So again, it's pretty high. Um, Even in the general population, it's pretty high. And so really what I generally say to patients is that, an eye that has a tendency to drift out, even when we mechanically bring it back in by, for example, shortening the inner muscle on the inside and loosening the outer one. So, the idea is you're increasing the inward force and reducing the outward force even though you're mechanically moving the eye by changing the muscle structures, there still is that same tendency to drift again. And so, I usually say to patients it can be anywhere up to about 50%. So even in doing the surgery, there's a significant probability we're going to have to do it again in the future. I will say there's certain nuances to that as well. Is patients who have very good depth perception, it tends to hold a little bit better because the brain wants to hold the eye there more than someone who doesn't have depth perception. So again, there are certain patient characteristics that impact that a little bit. But the risk is certainly substantial. And what I usually say is, if we're talking about doing it, is there's a significant probability we may have to do it again. So, and each time we do it, there's a little bit more scarring, and it's a little bit more uncomfortable to remove the scar to do the surgery. So that the minimum number of times we can do it, the better. And so again, my criteria are, is it impacting the vision, visual development? Is it impacting the development of depth perception? Or is there another feature like it's affecting school or it's creating headaches or it's causing double vision up close? But again, my general rule is to leave it as long as possible until we need to do it. And then that way we just redo it a minimum number of times.
Great. This person says that their son has VEDS and narrow angle glaucoma runs in the father's side of the family. Many members have it, including his father. When would they be able to see whether that is an issue for this particular person? Like age-wise, like when does that present typically? And if it's there, should they expect it to be more severe because of the VEDS diagnosis?
That's a good question. It's not something that I've seen that I'm aware of being reported as a higher risk in VEDS. And I'm trying to think about whether there's any anatomical reason I would specifically expect it to be. And I can't think of one off the top of my head. So in terms of the age, the evaluation that's done, we often put a little mirror just on the surface of the eye to look at the drainage angle to see how much space there is. It's hard to do that in young kids unless they're asleep. But if they were going to sleep for any other reason and someone wanted to take a look, so this is slightly age dependent. But through to double-digit years, it's normally possible to try and get that. There's other ways of evaluating it that are slightly less invasive, that using like a type of high resolution ultrasound machine to look at the structures inside the eye that can sometimes be used as well. And so I think and there are other features such as even if we just measure the length of the eye, which we can do from the age of about 4 using the non-invasive machines that are usually available in most eye clinics. If the eye is relatively long, there's less chance that it's probably going to be a narrow angle, whereas if the eye is pretty short and the child is very far-sighted, then there's maybe a heightened risk. So there's sort of different things that we can try to get a little bit of a sense earlier on. And then really evaluation by probably a glaucoma specialist using gonioscopy would be the best way to directly answer.
Okay. Is there anything specific that the VEDS community should be monitored for when it comes to their eyes?
I have to concede, I end up seeing, of all the different connective tissue conditions, I end up seeing really relatively few VEDs. My sense is that there's not a huge number of problems. And so I think for the most part, I generally recommend, again, that's one of those, at time of diagnosis and periodic monitoring, and really if there's any acute change in vision at any point, they're really the features where I say then, we should definitely see you for sure. And just if it does involve any vascular structures in any way, then just seeing as soon as possible is advisable.
Okay, great. Is it common for people with Marfan syndrome to get cataracts early in life?
Generally, yes. So generally, cataracts do develop earlier than the general population by usually about a decade or two. And so certainly, patients starting to develop them in, 40s or 50s rather than 60s or 70s is not uncommon. And for lenses that are very displaced and have displaced out the way, they can progress, even earlier and become even denser. And they're the ones that really we worry the most about, those leakage of proteins and the inflammation and the glaucoma that comes with it. So certainly not only monitoring the lenses for cataract in a lens that you can see, but also monitoring for lenses that are tucked out the way that you don't always look at, and checking for pressure and looking for signs of inflammation is something that I will always do at eye exam in patients who have those.
Okay. And I had a similar question about Stickler and also VEDS. So there are a lot of questions around cataracts and
Yeah.
connective tissue conditions. Same rules generally apply then.
Yeah, so generally, the lenses, yeah, occasionally in stickler, but rarely otherwise. Most of the time the lenses are visible, they're not out the way. So stickler, certainly I have had patients, I think, as I mentioned, present with stickler syndrome with cataracts very early in life. But certainly they can develop later as well. So yeah, certainly monitoring for those, but for stickler, that will usually get picked up because there'll be the regular monitoring for the retina anyway. So certainly, cataract development, it can be picked up and is usually visible. In terms of VEDS as well, then yes, again, it's something, if there is, a reduction in vision, glare, a lot of the time, cataracts can start to cause not only reduced vision, but glare features where you get lights and you get high halos around lights, particularly driving at night. They're all features as to why someone should go and get evaluated to check for cataracts.
Okay. That's all the time we have today. Many thanks to everyone who submitted questions and to Dr. Doyle for sharing his expertise and insights. If we weren't able to get to your question today, staff in our Help and Resource Center can assist with questions about your specific situation. Please visit marfan.org/ask, and a member of our team will be in touch. Again, thank you to our speaker, Dr. Doyle, and to all of you for joining us. Take care and enjoy the rest of the conference.